Welcome, everybody. I'm Sam Frentzas, co-founder of the Driving Force Company, and this is the Med-Legal Greenroom Podcast. And I want to absolutely so excited to welcome Dr. Andrea Trescot. With so many initials after the word MD, I can't read them all. I want to thank you and welcome you to the podcast.
Well, thank you so much, Sam, for inviting me. I appreciate it.
My pleasure. I was looking through all your credentials because I know when we first talked, it was easy, and then it was one full page from past president of the American Society of International Physicians
Interventional.
of Pains, yep, to your author of a 900-page text of the perennial nerve entrapments and
Peripheral,
clinical
peripheral
peripheral,
nerve, peripheral nerve entrapments. Yes, sir.
yep, clinical diagnosis and management, 200 peer-reviewed articles and textbook chapters. It goes on and on and on. Holy cow. I mean, so there's no doubt of who you are and what you can do. This was bordered on the ridiculous. And on top of all that, which I know this is going to make my business partner excited. Thank you for your service and being a commander in the Navy with 2 medals of achievements as well. So if that's not the cherry on top, I don't know what is. So welcome and thank you for being here.
Well, thank you so very much, Sam. I appreciate it. You and I had started talking about ligamentous injuries and how important I feel they are. And it was actually triggered almost more than 30 years ago, actually. I had had a I had always wondered about patients who would have these injuries. They would complain of pain in a whole variety of very different places, and they would have an MRI that was read as, straightening of the cervical spine secondary to spasm. And that in itself never made sense to me because when you look at the inward curve of the neck or the inward curve of the back, the muscles attach from here to here. And if they go into spasm, that should cause more curvature, not less curvature. Didn't make sense. And then I would examine them, and they'd have these areas in between the spinous process that was tender. And if it was an acute injury, it would be very boggy and sore. If it was an older injury, you could actually feel in between the spinous processes. Okay. And then they would have these pains going down their arms or going down their legs, which didn't make any sense because there was no herniation that was sitting on those nerves. And then a chiropractor gave me a copy of a article on by a fellow named Kellgren in 1935, where he took medical students, and of course you could do anything with medical students in those days, and injected hypertonic saline into the ligament and would get a ridiculous pattern of pain just into the ligament. And then one of my pain textbooks, I ran across a picture that showed that the innervation of the ligament came into the spinal column at the same level as the leg or arm nerves. And I'm going, okay, this is therefore a referred pain, very much like if you had a heart attack, you might have pain or numbness going down your arm. Nothing wrong with the arm nerves. You wouldn't operate on those arm nerves,
Right.
but it's because the nerves that go to the heart and the nerves that go to the arm come together at the same level of spinal column, and the brain interprets that as pain going down the arm. And but it's still, I couldn't quite put it all together until I ran across some pictures that I want to share with you all because it sort of made the believer out of me and then made the treatment that I do make sense. So if we can let technology to do what it's supposed to do, we're
Right.
going to talk just a minute about some of these ligamentous injuries. So if you look at the lumbar region, you have that nice inward curve of the spine. These are the spinous processes. These are the facets or the joints in the spine. This is the disc, even pressure on the disc, nice center. The disc has a nice soft center and a fibrous outside covering, and this nice strong ligament that runs from the back of the head down to the tailbone. And that's what holds it all together. When you get an injury in the lumbar region, the patient bends over and feels a pop. They get thrown forward and backward in the car. We said the pop was a herniated disc,
Okay.
but instead, this concept proposes that it's actually a pop of the ligament. And that puts a forward pressure on the disc and makes the disc bulge out. So the bulging disc is the consequence of the ligamentous injury, not the cause of. The loss of lumbar lordosis is the consequence of the ligament problem, not
Okay.
caused by the paravertebral muscles. The paravertebral muscles are now then trying to hold the spine together, and they go into spasm because of the loss of lumbar lordosis. Looking at it differently. So in some of my lectures, I'll actually show some of the optical illusions. You look at this picture, do you see the picture of a saxophone player, or do you see a woman's face? Depends on which you're focusing on.
Right.
The joints, the facets, which we treat all the time, are become inflamed because they're rubbing. They're moving too much. The disc starts to move back and forth. It degenerates faster. And so you get this accelerated degeneration, these pain patterns, because if the ligament is injured, then you'll get pain going down the leg in this situation, even though the bulging disc is central, not pushing on either leg nerve, because it's not a problem with the leg nerves, it's a problem with the ligament. But the hard part came in trying to image this, trying to recognize it, and trying to show. I mean, I could feel the ligamentous laxity, but insurance companies weren't very impressed with that. And the radiologist, as they're saying, it's because of spasm that they got the loss of lumbar lordosis. When you look in the neck, those flexion extension injuries, even worse, because you've got a very much more mobile structure. You get a stretch and a tear of these ligaments, and that nice strong ligament where you shouldn't be able to feel the spinous processes, all of a sudden now is stretched. The head becomes too heavy to hold up, and the joints start to move. Forward pressure on the disc bulges out, the paravertebral muscles go into spasm. You get an accelerated degeneration, the degenerative changes of the disc and of the facets, and this waviness, laxity of the ligament. The muscles are trying to hold the head up, they go into spasm. So we're busy doing trigger points in the trapezius muscles when the problem is the ligament. And then you get entrapment of the occipital nerve. So you get headaches, referring to the front of the face, from the spasm of the trapezius. All of this, we treat the occipital nerve, we treat the trapezius, we treat the facets, do epidurals for the disc. None of it is treating the underlying problem. Now, I look at my own MRIs, and I can sometimes see on very dramatic situations. Here you see a herniated disc, and of course, nobody paid attention to the disruption of the ligament posteriorly. So that's what I found was so fascinating with the idea. I mean, I had seen some DMXs before, the fluoroscopy and watching them shift, but you're sort of trying to look at it. Can you freeze frame it? Can you make a picture of that? I'm there trying to show to the patients, well, there's a little bit of movement, but how much is that? And even more importantly for me, am I going to be able to show that disappears when I try and treat the ligament? So that's where the things you were talking about really resonated with me.
So increasing, so image of increased vertebral movement is so important clinically.
Has to be a ligamentous problem. Has to
Okay.
be. And from that, you then can validate. I mean, often the patients say, I feel the shifting from side to side. How are you gonna view that on a static MRI?
Got it. So this is not just a ligament problem.
The ligament is the underlying
Got
problem,
it.
which leads to the facets, the herniated disc, the paravertebral muscles, the headaches, the pain going down the legs, and all the treatments that we're doing are treating just the symptoms and not the underlying process. So the patient gets temporary relief, but you never fix the problem. I use the analogy that if you hit a pothole with your car, you're going to throw off the alignment. That causes an increased wear and tear on the tires. I can change out the tires, but if I haven't fixed the alignment, I'm going to get the same accelerated degeneration. And so
So
putting in a disc, doing a fusion there where the ligament is still unstable is going to lead to instability above.
So you did bring up the DMX, and I just want to. So how does the VMA appeal to you compared to the DMX? Because I know we're talking about ligaments and technology, so I'm going to ask flat out: how does the VMA appeal to you compared to the DMX?
Well, I've had no success in trying to get radiologists to comment on the ligament laxity. That I can point to you, I can point to the patients. They go, "Oh yeah, that looks like ligament laxity," but I have yet to find a radiologist who will listen to that. So to have dedicated well-renowned neuroradiologist who not only say, yes, this is a problem, but can give me a quantitative assessment of it, of exactly what level is the level that's moving. And then I can combine that with my clinical findings. So for instance, patient has a pain going down the arm when they turn their head in a certain direction, to be able to show that the movement is closing down on that foramen. It's not the disc, it's the movement. Then validates what the patient's saying. It is a radiculopathy, but operating on that disc is only going to make things worse. And so being able to confirm that the patient's truly having those problems from a medical legal point is huge. It's also huge, though, for the patient's sense of of knowledge. That's why they're desperate to have a name to go with what's going on with them. What is the name of what I have? And even when I give them, I've had the situation where I give somebody a terminal diagnosis and they go, thank God, it's not just all in my head. So I'm going, okay, all right. But they really do sometimes feel as though nobody listens, nobody believes. Here it is, documented, measured, defined by not me, Dr. Trescot. So when did you do your radiology residency? Well, I didn't, but I've been looking at MRIs for 30 years. No, I'm sorry. Did you do a radiology residency? Did you do a radiology fellowship? So here you've got a board certified standard radiologist who says they don't see anything. How can the jury think that what you see is actually accurate? So now to have somebody who is the board certified fellowship trained neurologist to be able to give me the very specifics of each problem, and then the documentation and the pictures of that, I think, are going to be extraordinarily useful for my medical legal cases, and also to be able to provide the really definitive targets when I'm looking at trying to treat the patient.
And then what's a good treatment? So now that you're able to quantify an injury like this, what would be a good treatment when you can quantify this injury? And what would be a good treatment for the patient?
Well, it's very interesting. I can certainly do a percutaneous discectomy. I actually go in with a needle and I can suck some of that disc out. Doesn't make it more stable, but it pulls the disc off, in this case, the spinal cord, where that is trumping everything else. I can inject the facets, the joints in the spine, and I can actually even kill the nerves that are going to the joints in the spine. So the facet joint injections and either radiofrequency or cryoneuroablation. I can put botulism toxin or Botox in the muscles that are in spasm. I'm concerned that actually makes it less stable rather than more stable. I can put a spinal cord stimulator in the epidural space to treat the pain going down the arm. I can do I can freeze the occipital nerve. I can put a stimulator on the occipital nerve, but all of those are only treating the symptom. And so, what has fascinated me has been the ability to do regenerative medicine. And there are a whole there's a whole continuum of things we can do. The oldest and the thing I've done the longest is something called prolotherapy or fibroproliferative therapy. And there you can inject a an irritating medicine, in this case, usually a high concentration of sugar solution, that triggers the body to lay down new tissue. And so it's very much like putting a piece of sand in an oyster to get a pearl, or to do a chemical peel to get new tissue growing underneath it. Or I also talk about a control burn in the forest to get new growth in the forest. We can take your blood and spin it down and pull out the platelets. Now, it's the platelets that help lay down new tissue. So then we can inject the platelets along the ligaments. I can take your stem cells out of your bone marrow, aspirate the bone marrow, split it out. So we've got bone marrow concentrate that has a high concentration of platelets in there. Interesting enough, we can actually even take the platelets out of the stem cells out of your adipose tissue. Not as much as we all need, but the doing basically a liposuction and then breaking that down. And there's surprise, surprise, a ton of stem cells that are in the adipose tissue. And then we can use, if somebody is older, I've got patients who've had chemotherapy for things like leukemia years ago, so they never really have good stem cells themselves. We can do the stem cells from umbilical cords, amniotic placentas. And then, interesting enough, we've even been looking at something that are called exosomes. And when the platelets get to where they're going and they release their chemicals to pull the stem cells in, those chemicals, we can now create plants that can make those chemicals, and they go into into little packets, and we can inject those packets called exosomes and stimulate the growth there as well. So that regenerative medicine, I think, is what then fixes the instability. It's fixing the alignment. So now the tires don't wear out as much. Now you don't have the disc degeneration, you don't have the increased facet movement, you don't have the headaches because of the ligament laxity in the neck and causing the trapezius muscles to go into spasm and entrap the occipital nerves. And so that really, of all the things I do, that's really what we call the C word, the cure word, of actually fixing the underlying process. Not covered by insurance, but of course, because that's the never have something that you can never pay for something that actually fixes a problem. That would put it would put the spine surgeons out of business, I'm afraid. So there's a lot of resistance to that, but it has been extraordinarily rewarding. It used to be that was the very last thing that I offered a patient as a treatment, and now almost every person I see has a component of ligament laxity in their pathology, where we're talking about knees or shoulders or hips, um, or neck and spine, like we would be able to see on the VMA studies.
But it sure beats surgery, though, right?
Absolutely. This is done by a series of injections in an in-office treatment, and makes you stiff and sore for a couple of days. Prolotherapy has to be done a couple of times because it's sort of like laying down tissue paper. The platelet-rich plasma tends to be more or one or two sessions. And often we'll have patients who have neck and back. And so we're like tightening down the spokes of a bicycle wheel. You're trying to balance those. As you get one under control, then you recognize the other is a problem, and then you've got to treat that. And then that changes the stresses on the other. So it can be a dynamic process, but it's been remarkable. Of all the things that I do, the regenerative medicine has been the most gratifying and gives the long-term potential fix. And for these auto accident patients, especially because they're usually young and healthy, I can do one session with a PRP and they're done and they're back to being human again. And it's extraordinarily gratifying. From a medical legal point of view, they used to not let me do it because they wanted impairment. And now I'm working with a group of lawyers who are going, yeah, if that fixes them, that's what we want. So it's a lot of fun.
Thank you. That was just intensely educational, which is important. I mean, the providers are out there, and the patients that need to get this information, understanding. Because again, I truly believe that regenerative medicine is far better off than surgeries. But if you could do that first, and if surgery is needed, of course, surgery is done. But I like having the options of being able to have a provider fix somebody and pinpointing where they can fix them, um, and not just saying, "Well, it hurts here. Let's just take a couple stabs at them and see. Hopefully, we get lucky."
No pun intended, yes.
Right? Well, thank you, Dr. Trescot, for this. This was absolutely fantastic, and I appreciate it. So this is concluded here with the Med-Legal Green Room, Dr. Andrea Trescot. So we'll get this out there and make sure that this education and what you're talking about, our viewers, our followers, get a chance to see this.
Good. I'm glad to help. And thanks so much for the work you do.
Thank you.